Hello, this is Dr. Lynn McPherson from the University of Maryland School of Pharmacy, back with my colleagues, Drs. Brandt and Stewart, for Part 2 of Module 1, Principles of Palliative Care, in the electrifying course, Medication Management in Patients with Advanced Illnesses. The objectives for this module are to define and differentiate between empathy and sympathy, and to list 3 tips for effective communication, and last, to determine what psychological issues may affect a patient at the end of life within a patient case study. So let's see what's going on here. So, communicating bad news. Nobody wants to give it, nobody wants to hear it. But how do we break bad news to someone who has an advanced illness? I think it is important to prioritize your message and to be really careful not to use really fancy $10 medicalese words. You want to prioritize the key medical points. You want to assess the patient and individualize the discussion accordingly. And some of your considerations are, what is the patient's emotional state? I mean, put yourself in the patient's state. If you hear, "I'm sorry to tell you you have cancer," you pretty much don't hear anything after that sentence. You immediately go to, "Am I going to die? I'm going to miss my children." So it's really kind of a shock. It rocks you to your core. You want to assess how ready the patient is to engage in conversation. Often at that very first breaking the bad news conversation, it's a very abbreviated conversation and you have to revisit it time and again. You also want to assess their level of understanding of the medical condition. You always want to provide accurate information, but you don't want to give false hope. So, if you give a message that's 90% accurate and 10% false hope, what are people going to grab a hold of? That false hope portion. So you definitely want to avoid mixed messages. So as I just said, multiple conversations or visits may be necessary to revisit what is going on. You want to be cognizant but not assuming of the patient's background. You can't assume, oh, you're a certain age, so you must have gone through college and understand what I'm talking about. But people vary widely in terms of religious differences, cultural differences, and generational differences. Some things to avoid. Things could be worse. Well, you know what? If you just told me I had cancer, I'm hard-pressed to think how things could be worse. And to say, "I know how you feel," well, unless you've had cancer yourself, how do you know how it feels to be diagnosed with a fairly devastating diagnosis? These platitudes such as "time heals all wounds." What do you think, Dr. Stewart? Does that one work for you?
I hate that one. And actually, the one next, "God does not give us more than we could bear," is one of my most hated phrases of all times. What does this mean? If I was a weaker person, would I not have been given this awful diagnosis? So I think we really put patients in a bad spot when we use these phrases.
Okay. So, is bad news ever a good thing? Well, that sounds kind of like a strange thing to say right there, but in fact, I would rather know the bad news and get the 411, get the scoop, so that I can make some decisions and move forward. So hopefully by breaking the bad news in a very sensitive way, it can improve the patient's ability to plan and to cope. You certainly want to encourage realistic goal setting, and certainly it's difficult to do this sometimes while not completely stamping out their hope. But if someone has an unrealistic goal, like, "I want this cancer to go away and I'll be perfect again," when you know it's stage 4 cancer, that's very unlikely to be a goal that you can achieve. As best you can, you want to support the patient's autonomy. Provide opportunities to support the patient emotionally. It can be a devastating conversation. And strengthen relationships and foster collaboration between the patient, the family, the caregivers, and the healthcare team. Now, this is an important slide. Empathy versus sympathy. Wow. Sympathy is feelings of sorrow for another who is experiencing misfortune. So feeling very sorry for someone. Whereas empathy is the ability to imagine oneself in the situation of another. So I know when I was in pharmacy school, one of my professors talked about empathy. I remember he said, so you're a community pharmacist and someone comes running into your pharmacy and they're mad as all get out and they start yelling at you, and you're supposed to say back, "You seem to be upset." And I remember thinking, that is the silliest thing I've ever heard of in my whole life. But then when I graduated and became a pharmacist, I actually tried it, and you know what? It works. So empathy doesn't necessarily mean I agree with you. If you get very upset about a situation and I think it's silly to be that upset, I can still keep those thoughts to myself, but empathize and acknowledge your feelings for the situation. So empathy is the ability to imagine oneself in the situation of someone else. What is compassion? It's empathy coupled with an active desire to alleviate the suffering of others. Pity really has no room here. Feelings of discomfort at the distress of another. Dr. Brandt, these words are very closely intertwined and hard to parse out. What do you think?
I think the key distinction is really putting yourself in that situation and then really relating to helping that person, I think, is the tipping point for the compassion. And so, as many of us have been in this field for a while, you can see someone who's truly compassionate and gets it versus someone who just is pitying that person for being in that situation. But it's a skill that takes time to develop.
It does.
It really does. And I think really where experience and conversations and how people deal with these tough decisions, it makes you more of a compassionate provider.
I think many times young practitioners feel like they can never show their feelings of empathy or unhappiness for the patient in front of the patient. I'm not saying you should break down and start sobbing uncontrollably in front of the patient, but I think it makes you look more human when the patient can see that you are distressed for them, which I think is an empathy, compassionate type of approach. What do you think?
I do. I think there's a balance, though, because sometimes I feel that the provider personalizes maybe a little bit too much and struggles with that. So I think there's a line there. I think showing emotion and understanding, but I think there's a balance of showing too emotion and maybe putting yourself in too much in that situation.
It's a tough line to straddle,
It
for
is.
sure.
You should never be crying harder than the patient when
Oh,
you
that's
deliver bad
that's a good
news.
rule.
It's a good one. Yep.
All right, so dying is part of the cycle of life. Why am I hearing the Lion King in the background here? It can bring patients and people and families closer. I think it is important to have honest discussions about prognosis. It's difficult to have, I left my crystal ball at home to say you're going to die in 42 days, 8 hours, and 14 minutes, but to kind of give them an idea of where they are in the cycle of things so that people can plan accordingly. I know in my work in hospice, we often petition to let the son out of jail to see mom before she dies or whatever it may be, but it is important to have an idea of what's going on to allow people to get closure. Preparing to die. Well, that sounds like a textbook right there. Certainly things we have to consider, the physical. If there are things that the patient wants to do, you want to do them while they're still not only physically but also mentally competent. We have to consider their emotional status, their spiritual, and then practical things. I think I'd mentioned this in the first part of Module 1, the finances. And we have many, many patients who do their funeral planning along with their estate planning. They pick out the music, they pick out pictures they want displayed, and so forth. So they may be more prepared for death than the process of dying. Why is communication important? Because it may make different medical choices. So it's very important to know all the options and the consequences, so the benefits and burdens. Communication helps us to provide education to the patient, the family, and the caregivers, to increase acceptance of the situation at hand, to provide closure, and of course, to reduce anxiety. So how do you prepare for these conversations? Certainly you want to know what's going on with the patient. You want to be very sure of your facts and what is going on. You do want to have a good idea of what does the patient want to accomplish or to discuss. What are their needs or concerns? I know I hang around with social workers a lot, and I guess my 10% inner social worker, even though I'm 90% pharmacist, is to ask questions like, what do you hope for? What is one thing I can do for you right now? What are you afraid of? To really cut to the chase and find out what's on the patient's mind. And you have to think through who needs to be at the meeting. You want the important players there that really influence the patient's care, but you really don't want a cast of thousands either. Some quick tips. Again, doing your homework in any situation is always a good idea. You want to pick a good time and place where it's quiet and private, not when people need to be leaving and running in and out. Confirm that the patient and the family want to talk. Consider the privacy issues. Is it all right if we talk about this or address this? And again, asking how much do you want to know? As I'm not a physician, I'm a pharmacist, so often I will say, what did your physician tell you already about your medical condition? And what do they already know, not only about that, but their illness as a whole and hospitalization course. You want to match the patient's communication style. You want to use simple terms that everyday people use. You don't have to use those $10 terms, those big medical terms. So you might say the breathing machine instead of the ventilator, for example. So take your cue from the patient. Certainly we have patients once in a while. I remember one fellow who had a PhD in toxicology. So when we talked about drug therapy, I think he was smarter than me. So I could kick it up a notch. Don't be defensive. And as I said just a few moments ago, I'm not afraid to show a little emotion. Certainly, I don't want to be bawling on the floor. And don't take things personally. And that's easier said than done. If someone's health beliefs are radically different than mine, it's very difficult for me to zip it and to just roll with that. I know we had one man of Asian descent who was vomiting ceaselessly, and I desperately wanted to recommend drug therapy to take care of this, and his adult daughter said, no, he has to suffer on earth so that he can go to heaven when he dies. So very much at odds with my own personal health beliefs, but I couldn't take that personally. Certainly want to listen. I think active listening is just as important as what you say. So full attention on the patient, letting them speak their mind and being kind, but being honest and open and caring. Silence is not always a bad thing. Sometimes people just need to sit with something and kind of let it soak in. Certainly, you're not doing a survey, so asking open-ended questions. So when you are completely stuck and you're thinking, oh my gosh, what am I going to say next? A good phrase is, tell me more about that. And it kind of opens the door. Dr. Stewart's nodding her head. What do you think about that strategy?
I love that phrase. And also, I like to ask patients, what's on your mind right now? Because sometimes they're thinking about things like, I came into the hospital for the ER last night, and nobody's home to let my dog out. So if you don't ask those open-ended questions, you might really be missing the ball.
That's important. And I think the last part here is really important. Clarify and affirm. So kind of summarizing what the patient just said to make sure that you understand what they were trying to convey, and it tells them that you actually did understand what they were trying to say. Review at the end and make sure everyone's on the same page. We do this in meetings here at the School of Pharmacy, don't we? So at the end we say, Dr. Brandt's going to do this, and I'm going to do this, and Dr. Stewart's going to do this. So at the end of a meeting, it could be, okay, the social worker's going to check on this, the physician's going to do this, the pharmacist will print out those education sheets about your medications, and you're going to discuss what you want in your advance directive. What is the plan from here? Documentation. If you didn't document it, you didn't do it. And then it's always very useful to debrief with the team as well. Useful phrases. What have you been told about your illness, the chemotherapy, the therapeutic options? What are you worried about? I like this phrase too, is I always ask permission, can I share with you my thoughts? Can I tell you what I'm thinking right now? And to say, you don't want to say, if someone says, I want to be cured, you can't say, well, dude, that's not going to happen. You're not going to be cured. No way, no how. To say instead, so I hear you, but what I'm concerned about is blah, blah, blah. The cancer is very metastatic. So my concern is it's unlikely that this medication, the chemo, will make this cancer completely go away. And as Dr. Stewart just said, what's important to you right now? What are you hopeful for? What I'm hearing you say. And often people refer to, I don't know, my son who, of course, lives in California, who is always a doctor or a lawyer. Am I right? They're always, the savior son from the other coast. If they were here with us right now, what would they say? Or it could be someone like, oh, I wish my husband was still alive. He would tell me what to do. Do you ever see that with your long-term care patients?
Oh, yes, definitely. They wish that person they've depended on for, as you saw with the case, for many, many years was here to answer those questions. The other one we use oftentimes too is what questions, so it gets away from the worries or the issues, but what questions are you hoping to get addressed, during this, meeting or during this discussion?
And, one of the best tips I ever learned was years ago. I was at San Diego Hospice, and the physician who was doing the rounds, when we were standing bedside with the patient, instead of saying at the end of the encounter, do you have any questions? He said, what questions do you have for me now? Which is subtly different and invites questions. Like, I'm expecting you to have questions, so what are they? Not, do you have any questions for me?
Absolutely. A play on words, but a very important one. So.
Other psychosocial issues at the end of life. Failing to address psychosocial issues is a critically important thing, maybe more complex or distressing than the medical issue, as I just said. And I agree with Dr. Stewart. We have had hospice patients who are more concerned about what's going to happen to their cat or dog after they die than anything else. So we have actually stood on our head to find a home for the pet so the patient can rest easy. If it was up to me, I would have 492 dogs right now, but I probably would also be divorced. But enough about me. There is a large unmet need for psychosocial support. Social worker, chaplains, a critically important part of our team, and this psychosocial distress can be huge in end-of-life care. Other psychosocial issues, emotional well-being, self-esteem. People do a lot of life review, and at the end, they're like, was my life worth living? Did I make a contribution? Was I just taking up space? Did I make a difference in other people's lives? Insight into their illness and its consequences. A lot of blame. Oh, if I didn't smoke, I wouldn't have lung cancer now. If I didn't drink alcohol, I wouldn't have cirrhosis now. So really dealing with that. Or people who have fallen away from their faith and now they're worried, oh my gosh, I'm going to go really down far south when I die and I'm going to be dancing with the devil forever. So people get very frightened about these things. Communication skills, social functioning, relationships. So many times we see relationships mended in the 9th hour. Very important. Unintended consequences. If we don't address these psychosocial issues, absolutely it can negatively impact care. Patients can become withdrawn, depressed, angry, even combative. So let's go back to our case of Ms. Smith. She agrees to have a family meeting and asks you to call her younger daughter, Emily, who is her decision maker. The potential benefits of this meeting for Ms. Smith may include making different medical choices, acceptance, closure, less anxiety, or all the above. What do you think, Dr. Stewart?
I'm pretty hopeful that it might accomplish all of those things.
Is that possible, do you think?
I think we're pretty special practitioners, so I hope so.
We are special, I will say that. So you're right, it is all the above. So hopefully if we plan our agenda correctly, if we stage our meeting, if we make sure that Ms. Smith is pain-free when we have this meeting, we can hopefully address all of these issues. Caregiver support. We've alluded to this already. Caregivers are prone to physical and psychological morbidity. And this is such an important point. I can tell you many times in hospice, we see the caregiver pass away soon after the patient because they've just been run ragged. So their needs may meet or exceed those of the patient. Many times we'll have a 90-year-old guy on hospice being taken care of his wife who's 89 years old. We've had people say, look, I can't die because I'm my spouse's caregiver. So the patient on hospice is taking care of a spouse that's just as sicker or sicker than them. So it can be very complex. So providing support is essential to successful end-of-life care. We want to inform the caregivers of the available services, and hospice programs are obligated under the Medicare benefit to provide bereavement services up to 13 months after the death. And hospices are operationalize this in a variety of different ways. It could be support groups held at the hospice or somewhere in the community. It could be telephone calls on important dates like Mother's Day, Father's Day, the patient's birthday, certainly the anniversary of the patient's death, major holidays, and so forth.
I've even heard of summer camps for children who have lost their parents in hospice programs.
That's really important.
They do some great things.
They do. So back to Ms. Smith. The family meeting goes smoothly until Roger tells the physician that his mother will live with himself or Emily rather than move to an assisted living facility if she can no longer live on her own. Emily interjects that she is, quote, already bringing mom meals and maintaining her house and driving her to her appointments. I just can't afford to take off any more time from work or I'll lose my job. Could Emily and Roger benefit from caregiver support? What do you think, Dr. Brandt?
This sounds very familiar. The discussion of a higher level of care or trying to maintain them in their current living situation spans lots of reasons, from, reality check, can we really do that, to financial implications in terms of the care. So yes, they both could benefit from some sort of caregiver support, and just basically setting realistic expectations for the two of them, depending on how long Miss Smith's illness is going to be happening for, right?
Absolutely. Very important.
Mm-hmm.
So yes, the answer is correct. So if you want to learn more about this topic, some principles of hospice and palliative care, we urge you to go to getpalliativecare.org so you can learn all about it from the Center to Advance Palliative Care.